Thank you, sir, for those kind words. And once again, thanks a lot, Dr. Mohan's team, for this opportunity. So, what I'm going to do is that I'm going to take you through a few of our own studies and evidence, and making a case that micro and macrovascular complication in diabetes is a continuum. These are no more distinct. So, we all know 40 years, 50 years, knew the pathogenesis of type 2 diabetes. It was a tumorate where we thought that it is insulin resistance into liver, muscles, adipose tissue, and a growing beta cell dysfunction, which sets in the stage for development of type 2 diabetes. And since then, we have come a long way in our understanding about pathophysiology of type 2 diabetes. From earlier days, I told you, to an omnious octet, which 2009 Benting oration, Dr. D. Fronzo said that there are 8 defects contributing towards pathogenesis of type 2 diabetes. Fortunately, we have Dr. Madhu here, Dr. Madhu, me, and Dr. Sanjay Kalra. We proposed this. This was a IGM publication 2015, that it is a dirty dozen of diabetes. It is no more only in omnious octet. And today we have publication talking about almost 15 to 16 defects contributing towards pathophysiology of type 2 diabetes. Today we understand diabetes is no more a metabolic disease. It is a vascular disease where there's a huge amount of vasoconstriction, growth promotion, a prothrombotic state, and a pro-inflammatory state, which leads on to endothelial dysfunction. And overall, per se, it is the endothelium-mediated vascular health which is impaired or unbalanced, which then sets in the stage for all micro as well as macrovascular complications. So hyperglycemia leading on to endothelial dysfunction, then sets in the stage for microangiopathy like retinopathy, neuropathy, nephropathy, and other vascular complication in diabetes. And the various potential mechanism by which hyperglycemia induced mitochondrial superoxide overproduction activates 4 pathways of hyperglycemic damage. It could be polyol pathway, through hexosamin pathway, through protein kinase C pathway, and advanced glycation pathway, and all together propagate all micro and macrovascular complication. The mechanism of hyperglycemia induced endothelial dysfunction, I told you, is through these 4 pathways which induce oxidative stress. There is endothelial dysfunction, a decreased nitric oxide production, a decreased prostacyclin, and increased angiotensin II, which then leads on to inflammation, thrombosis, vasoconstriction, and rampant atherosclerosis in the setting of type 2 diabetes. There are various studies, estimates on prevalence of various complications. One of the earliest ones said that if you take it together, micro and macroangiopathy, maybe 35 to 55 or 60% patient will have micro or macroangiopathy. One of the earliest ICMR data which talked about vascular disease in type 2 diabetes, which said that large vessel disease, coronary artery disease is seen in about 8% in males, and cerebrovascular disease, that time it is 1.7 only. PVD fortunately was always very, very low, but it was the microangiopathy, retinopathy contributing for 16%, and nephropathy contributing for about 15% of patients. So together, this is one of the earliest data which is published by ICMR talking about micro and macrovascular complication. Dr. Ramachandran's data, a very landmark study from this city, talking about 3,000 patients with average age of 52 years, and he said that retinopathy is seen in about 23%, nephropathy in 5.5%, neuropathy in 27% of patients, CAD in 11%, PVD close to 4%, and hypertension, of course, was there in almost 1/3 of the patient. We did a humble effort, almost 2004, early days, 20 years ago, we published a similar data, and this we presented at No Nordisk Diabetes Update at Singapore, and we got the best paper award there. We said that in 720 patients, retinopathy was seen in 21%, microalbuminuria proven on 2 accounts was seen in 41%, neuropathy in 15%, coronary artery disease 7%, PVD, like in Dr. Ramachandran data, was seen in about 4% of patients. So we come to the point that we generally consider micro and macrovascular disease in diabetes to have different pathogenetic mechanism. This is what is the conventional thinking, that they have a different time of onset related to glucose threshold for diagnosis. We also presume that these be linked prognostically as coexisting partners in diabetes, but not necessarily because of shared mechanism. We know that microangiopathy is there, macroangiopathy is there, and we also know that the successful treatment approaches both to micro and macro are again not very well aligned. This we are aware that when you are treating microangiopathy with the intensive control, you might be able to check the progression, but still macrovascular complication are not going to get sort of reduced even if you have a very tight glycemic control and you need a different approach, something like steno 2 type of approach, so as to cut down on macrovascular complication. So if you know the metabolic theory of diabetic neuropathy, there is a insulin independent glucose uptake. That is why whether you have type 1 with total insulopenia or type 2 diabetes, there is a direct uptake of glucose into kidneys, retina and nervous tissue. That is why you tend to develop microangiopathy, which has a very, very linear relationship in terms of what time and in terms of glycemic control. So all patients, they are at a very great risk if they have a higher glycemic level or they are having a long duration of diabetes. When it comes to pathogenesis of diabetic neuropathy, mechanisms are literal different through all these pathways. There is a vasoconstriction, sodium potassium ATP pump gets used. There is a endoneural hypoxia, nerve conduction velocity also gets impaired, and there is going to be a degradation of axonal structure leading on to diabetic neuropathy. So it's not surprising that if you look for a diabetic peripheral neuropathy evidence by doing a examination of tissues from patient with diabetes, you might see a capillary damage including occlusion in the vasa nervorum, which is there very early in the course of the disease. When it comes to diabetic nephropathy, again the mechanisms are little different. Through vasoactive mechanisms and through PKC pathway, we know there is a stimulation of cytokines, there is an increased vascular permeability, increased extracellular matrix and extracellular matrix accumulation, and then proteinuria happens. That is why it is very, very early you might find, if you try to compare glomerular structure in a normal person as well as in a diabetic person, you might find that there is a thickening of the basement membrane, which again comes very early in the course of the disease. So it is not surprising that you might have microalbuminuria might be at the time of diagnosis in many patients, those who have a subtle onset or those who have a undiagnosed diabetes going on for 2, 3, 4, 5 years, and you might have right at the time of diagnosis the presence of microalbuminuria. Similarly, diabetic retinopathy has been seen in about 21% of patients. The background diabetic retinopathy could be seen right at the time of diagnosis. There is a delayed diagnosis like 5 years down the line, and these patients then progress further in terms of worsening of both neuropathy as well as retinopathy. Even neuropathy could be seen at the stage of IGT. So in patient with unexplained peripheral neuropathy symptoms, if you do an OGTT, about 30%, 35% of them might have an abnormal OGTT. That means even neuropathy could be seen right at the time of diagnosis or even at the stage of pre-diabetes much earlier than it is anticipated. And in UKPDS trial, it was seen that by the time you have diagnosis of type 2 diabetes, about 50% of patients, they might have either microangiopathy or microangiopathy. 37% patient had retinopathy, 18% had albuminuria, and 10% had peripheral neuropathy. And we presented this data in 2005 very early, and we looked into 100 new onset patients with type 2 diabetes, and we found that there again background diabetic retinopathy was there in 10% of the patient right at the time of diagnosis, and even neuropathy was also common, and microalbuminuria was again seen at the time of diagnosis in 16% of the patient. That means the stage for both micro and macroangiopathy gets set in almost at the stage of pre-diabetes, maybe 5 years prior to the diagnosis. We did this study again to look into the prevalence of peripheral neuropathy, and we did a biophysimetric evaluation and look for its coassociation with other things. And we said that if you do a bedside examination, I am happy Dr. Bhansali has a lot of data on NNS, NDS, and we also published this data subsequently, that if you do this bedside examination, it can be an excellent tool for picking up peripheral neuropathy without doing very, very sophisticated tests. And in our study, the prevalence was close to 15%. What was much more important, which we realized gave us an insight about 20 years ago, that if you have peripheral neuropathy picked up by simple NSS and NDS score, that can have a strong coassociation with diabetic retinopathy and microalbuminuria, which are much more serious complication. Once it comes to the pathogenesis of vascular complication, we know macroangiopathy, it follows a ticking clock hypothesis. The onset of hypertension, dyslipidemia, or inflammation or endothelial dysfunction might set in almost 5 to 10 years prior to the onset of the disease. That is why microangiopathy, which follows since the onset a linear relationship, macroangiopathy or macrovascular complication might be there much earlier than anticipated, right at the time of diagnosis also, because we know it is per se hyperglycemia along with insulin resistance, which leads on to endothelial dysfunction. There is a smooth muscle proliferation, prothrombotic state, a atherosclerosis, inflammation, which then leads on to propagation of macroangiopathy. So it is suggested that there is a very strong interlink between micro and macroangiopathy, and it seems to be a continuum going throughout the course of the disease. So heart in diabetes is no more only a macrovascular disease, which we thought 10 or 15 years ago. Today we know a preserved ejection fraction, which is a microangiopathy. Without a fixed block, you might have a heart failure, because there is orchestra of contributing factors contributing to the development of cardiac myopathy, which is concerning fatty acids and glucose. So heart in diabetes is no more a macrovascular disease, it is also a microangiopathy because of common soil hypothesis of diabetes complications. So changes in small arteries and capillaries are not only responsible for microangiopathy in long term, but also like retinopathy, nephropathy or neuropathy, but also for other manifestation of heart disease, which today we know a preserved heart failure or a mid-range heart failure, if you do an angiography, they might have absolutely normal coronary artery disease. So normal coronary arteries. So it is actually the endothelial dysfunction which sets in much earlier, and it can be fortunately picked up by doing a flow-mediated vasodilation, which could be done on the bedside by using a 2D echo. And this is what we did almost, this was I think 2005, we presented this data. A flow-mediated vasodilation as a marker of endothelial dysfunction in obese, diabetic and coronary artery disease patient and North Indian patient. These were 16 patients in each group, total 80 patients, except the lean, thin ward boys of our hospital who had a normal flow-mediated vasodilation. Even the obese with diabetes or with coronary artery disease or diabetes with coronary artery disease, all these patients, they had a impaired flow-mediated vasodilation on bedside, and it was only the lean group which had 11.26, which was at that time taken as a normal flow-mediated vasodilation as it was picked up from the brachial artery. We also looked into the prevalence of cardiac autonomic neuropathy in recent onset patients, and we found that 143 subjects who were evaluated, 57% of them, they had a normal neurothiometry. They had no peripheral neuropathy. Out of 35 subjects who had diabetes only for 1 year, less than 1 year, when they were subjected to dialysis, a gadget which can pick up cardiac autonomic neuropathy much early in the course of the disease, because it is very, very sensitive. It's a US FDA approved gadget to pick up cardiac autonomic neuropathy. It was seen that 71% patient during first year of their onset of disease, they already had cardiac autonomic neuropathy. So that brings us to a point that is there a glucose threshold that establishes a clear cut, real cutoff for the diagnosis of type 2 diabetes, and whether this diagnostic cutoff is aligned to microvascular disease or no. There are studies like 3 large population studies like OSDEP, MESA and Blue Mountain cross-sectional data, which have looked into diabetic retinopathy, which is possibly the best parameter to look for a linear progression of the disease. And in this, it was seen that even if they had a normal HbA1c 5.5 and you follow them within 5 years, many of them might have development of retinopathy subsequently, even if their HbA1c is going only up to 6.5. That means this could happen right very early, almost since the onset, and you never know that what today we say is a normal fasting 100, tomorrow could be 97 milligram, because cutoff for retinopathy is actually 98, 99, and so is for coronary artery disease. Because we know that there is a strong relationship of retinopathy to coronary artery calcium, what has been seen in VEDIT study, And even in the ERIC study, it has been seen that moment you have onset of retinopathy, there is going to be a increase in coronary artery plaque. So there is going to be reduction in your survival rate. ERIC study also established that microvascular disease like retinopathy and heart failure again go hand in hand. Now, this heart failure, that time we were talking of a macroangiopathy. That time we didn't know that a preserved heart failure or a mid-range heart failure is also there. We were talking of only a systolic heart failure, and it had a direct relationship with retinopathy. If there is a progression of retinopathy, heart failure is going to go up, and so is going to be the increase in overall cardiovascular mortality also. Blue Mountain is again a wonderful study which has looked into retinopathy, that it could predict coronary artery disease mortality. Moment you have retinopathy along with diabetes, your overall increase is going to be there in coronary artery mortality as compared to someone who has no diabetes, no retinopathy, or simply has diabetes but no retinopathy. So that means from retinopathy you can predict that there is going to be an increase in coronary artery disease mortality also, and even retinopathy could predict overall CV mortality both in men as well as in women, because today we know that retinopathy not only predicts CV death, it suggests that there are common background pathways for both micro and macroangiopathy, and they share the common mechanism of common soil hypothesis. That is why there is a progression in terms of not only retina but also in coronary artery disease. And this is we published 2021 in Primary Care Diabetes, a data of almost 3,000 patients from my own center. We tried to establish a relationship between diabetic retinopathy, microalbuminuria, and other modifiable risk factors, and we found it is again a very, very strong coassociation, not only of retina and microalbuminuria, but also with many modifiable risk factors for CV disease. Hoon study we know has established that microalbuminuria has an impact on overall CV mortality over 5 years. So moment you have presence of microalbuminuria or worsening of micro to macroalbuminuria, not only there is going to be a progression in overall albuminuria, but also there is going to be increase in CV mortality at 5 years. We did this presentation at ACE in 2019. We said that there are novel metabolic score based on pentad of clinical, biochemical, and radiological profile. We looked into the last session, we were talking about lean MASLD patient. We looked into 85 patients, those who were lean, they were diabetic, and there also we found even if their BMI was less than 23, they had significant presence of MSLD as picked up on fibroscan. And we also published, this is in Journal of Diabetes, Dr.Mohan journal, a correlation between cortical renal thickness, the length of kidney, and the ratio between cortical renal thickness and estimated EGFR as a predictor of diabetic nephropathy patient. If you follow these patients, if this is going to have a strong correlation with the worsening of EGFR. Another study which published in IGM, evaluation of platelet volume indices as predictive biomarker of microvascular disease. We looked into platelet width, band length, and overall the numbers of platelet, and we said that they could predict the presence of microvascular disease. So this was again a awarded paper at ACE. We got the Traveller grant on this paper, and it appeared in Endocrine Practice as a commentary also. We have been sensitizing all physicians. Now I'm editor-in-chief for IJGDC journal, and I've been talking most of the time in my editorial on clinical topics that screen for peripheral neuropathy, do it early so that we could save limbs and lives. I also talked about in one of the editorial hyperinsulinemia, obesity, and type 2 diabetes, again talking based on various studies that it is a continuum. Most of the time we write an editorial based on the publication which are there in that particular issue. So we picked up 4 or 5 articles and we looked into that, what we have been saying for 20 years, hyperinsulinemia, obesity, type 2 diabetes, it is all a continuum of the CVD, and diabetes and metabolic dysfunction associated steatotic liver disease. Again, it is a continuum. That means micro and macroangiopathy through different mechanisms, they are contributing towards overall progression of the disease. And this is last year we published in Endocrine Practice, resistive index on renal Doppler as an early marker for detecting diabetic retinopathy. Again, this paper was widely appreciated. So may I sum it up saying that there are shared mechanisms a link between micro and macrovascular disease, the neovascularization which contributes to the delivery of adhesion molecules, cytokines and chemoattracting proteins also contributes towards atheroma as well as to the development of retinopathy, and there is a strong link between hyperglycemia, which is not only leading on to micro but macroangiopathy, PVD and coronary artery disease. Early days we looked into the presence of lead and PVD in type 2 diabetes, and we said it has a very strong correlation with hypertension, coronary artery disease and albuminuria. We also tried to establish a link between peripheral neuropathy and PVD, and surprisingly, otherwise baseline PVD in India, northern India is 4%. In the study which had peripheral neuropathy, the PVD was very, very high, close to 25 to 26%. And we said that there is again a strong correlation between autonomic neuropathy, peripheral neuropathy, as well as co-association with PVD. So in this, we said that these patients in the test group, those who have already peripheral neuropathy and cardiac autonomic neuropathy, they also have higher parasympathetic failure and they have a sympathetic dysfunction. So we said there is a strong positive correlation between autonomic neuropathy and peripheral neuropathy. So we sum it up by saying that hyperglycemia is the principal cause of microangiopathy, but it also appears to play a very, very important role for causation of macroangiopathy. So what is conventionally thought, there is an intersection between micro and macroangiopathy, but we say that it is a more of a continuum. So today we must assume that type 2 diabetes is no more a metabolic disease but a vascular disease, and one of my publication in IGM 2015 summing up based on that evidence over last 20 years that micro and macrovascular complication in diabetes are no more distinct, but they are continuum of the same phenomena based on our own data over last 20 years, and many of these slides are from my own book, that is Complication of Diabetes. Thank you very much for your patience listening, and I'll be happy to have certain questions toward that. Thank you.